let's see. So what I'd like to do is talk to you a bit about disparities. We've done a great deal of work. I work at Mount Sinai Hospital just down the street, very poor safety net hospital in a very poor community. And we've done a lot of work on disparities. So let's see, what are these? Yeah. So I'll talk about that and then talk about what we do about those disparities, and then I want to talk to you about community engagement, and then wind up by trying to talk about the questions Shirley asked me to answer in my talk, which of course were profound, and I have no idea what the answers are, but I'll raise them with you and we can discuss them again. So you may not know this, but the United States government has been made aware of people struggling, as Jane said earlier, about disparities in health, inequities in health, unfairness in health, and so has a whole vocabulary and a funding mechanism to allegedly do something about disparities in health. And so, but there is no way, so there's a huge amount of funding. I mean, when I say huge, I mean huge. Billions and billions, that's with a B, of dollars to eliminate disparities in health. And whether any progress is made is unclear, and there's no real paradigm or model for examining whether we're making any progress. So 10 years ago or so, my colleagues and I at the Sinai Urban Health Institute, Mount Sinai Hospital, set out to try to examine such a thing. And so quite a few years ago, it's amazing, we wrote a paper in 2001, and I don't know if any of you have noticed this, but the years keep progressing, but I don't ever get older. And I don't know how that happens. How many of you have experienced the same? So anyway, we wrote this paper in which we began to try to say, okay, we say we're doing all the stuff around disparities. What kind of progress are we making? And so we published this in a peer-reviewed journal. By the way, this is all on our website, and the website is in the handout. Rennie was kind enough to duplicate these slides for you. So our website is there on the cover page. If you want to look, all these papers are there in PDF format. And then so a couple of people wrote that they liked what we were trying to do and made suggestions about how to improve that. And then, so they wrote papers, and then in response to their papers, we wrote this other paper, which was the American Journal of Public Health. And again, this is on our website, I won't talk about that. And finally, we wrote a third paper, and this is the one I want to talk to you about in just a little bit of detail to set the stage. And what we said we would do is, we want to see if disparities are decreasing, and we look at them in both Chicago and in the United States. And we chose 15 measures of health called health status indicators. And we compared black people, the NHB and NHW, for those of you not used to the vocabulary system, non-Hispanic black and non-Hispanic white. If you're interested, we can talk about that later. And what we would do is we would look at the differences between in 1990 and 2005 and see if the disparities were improving or not. And when I say improving, I mean if they were decreasing, right? And so that's the model, that's a setup that we did for both the United States and Chicago. This is the paper that appeared in the American Journal of Public Health. And now this is a test. How many measures did I say we would look at? 15. So 10 of them, good, I'm just going to quiz you throughout this. And Shirley, you'll be writing down people's responses. So among the 15 measures, we had 10 measures of mortality, of death, and these are the usual ones, you're familiar with them. No one would differ from these very much. They might put one on and take one off, but these are the 10 measures of mortality. How many more measures do I have to show you? 5. Okay, 5 more. So here, 3 of them were measures of birth outcome. Infant mortality, low birth weight, and no prenatal care the first trimester. Again, no one would differ much with those. And now how many more do I have to show you? Okay. And they were measures of communicable disease, primary, secondary syphilis, and tuberculosis. So that's some of the methods. I won't discuss that, but let me show you the results. Okay. So this is all-cause mortality, that is the overall death rate. And here's how these graphs work, and I'll show you several more, but we'll just spend some time on this one. In 1990, this is the top one. You can't see the colors so well on the slide, but is the black rate, and the blue line is the white rate. And in 1990, the death rate for black people in Chicago was 36% higher than for white people in Chicago. That's an awful disparity. Just terrible. 36% higher, more than a third higher. And then in 2005, it was 42% higher. So as awful as it was, it got even worse. Okay, and we put the star there to mean that the difference was statistically significant if you're familiar with those statistical techniques that we use. So an awful change. Now, notice though, I have to be clear, what we're concentrating here on is the disparity. And so both rates went down, which is good, but the white rate went down even faster, and so the disparity opened up, and that's terrible. It was bad enough at the beginning, and then in the end, even worse. So here's the same kind of graph for heart disease mortality, and again, you can see in 1990, there was almost no disparity. The rates were almost equal, and by 2005, a 24% disparity. So disparity opened up enormously. Again, both rates improved. I don't want to mislead you in any way, but the disparity opened up enormously. Now, we have done a lot of work on breast cancer, and this is the heart of it. And I don't know if you quite can get it, but, oh, I'm so sorry. But in 1990, there was a 20% disparity. That is, the death rate from breast cancer for black women was 20% higher than for white women. That's bad. But look what happened 15 years later, in 2005, it was 99% higher, almost 100% higher. The death rate for black women in 2005 was 100% higher than for white women. And what happened was the disparity opened up. By the way, we have data in 1980, the rates were equal. So what happened? Well, I'll tell you what happened. We began just around 1990, maybe a little later, to make progress. Shirley, would you give Marilyn a demerit for coming in late? What happened was in 1990, and this is a huge manifestation of racism, and I'll be talking about that a lot as I move along. But in 1990 or so, we began to make progress with early detection, mammography and so on, and treatment for breast cancer. And what happened, and this is in Chicago, throughout the city, was that white women were able to gain access to those advances. And so their death rate went way down. The death rate for black women didn't change at all. And so in this 15-year interval, and in fact, again, we go back to 1980 with the data, so a 25-year interval, black women in Chicago made no progress whatsoever, none whatsoever, in breast cancer mortality. And so their rate in 2005 in the paper is same as 1990, but data we have the same as 1980. So this is just a huge finding. We didn't expect it, but it led to many other developments, which I'll be talking about in a little while. Diabetes mortality, this is interesting. The disparity narrowed a little bit, but the way it narrowed was because neither rate changed hardly at all. So there really wasn't any progress. Here's another one, for example. Now, the disparity narrowed from 141% to 105%. It's still enormous. That is, the number of babies born at low birth weight is 105% higher for black babies than for white babies. And the way this disparity narrowed was that it got worse for both white people and black people. But it got worse a little faster for black people, and so the disparity narrowed, which is normally good, except it happened by everybody getting worse. So anyway, I could go on for hours about this, but won't. But in summary, of the 15 measures for the United States, of the 15 measures, 5 of them increased, 6 of them increased. Is that good or bad? That's bad. 6 of them increased, 8 of them decreased, that's good, and 1 stayed the same. So in summary, of the 15 measures in the United States, there was a little small bit of progress in the 15-year interval, but virtually none. Virtually none, 6 getting worse, 8 getting better. So it's slightly in the right direction, but really not at all. And in Chicago, 11 of the 15 got worse, and 4 got better. So in Chicago, we have seen absolutely no progress. We've moved dramatically backward in eliminating racial disparities in health. In our paper we wrote, and we called it the backward propulsion. We're going backward, and we're going backward quickly in reducing disparities in health. Mind you, this is after billions and billions of dollars, literally, have been spent on this effort. And I can tell you later where it's on if you're interested in it. But billions and billions of dollars. So I won't go through that. So these are numbers, but the implications when you bring it onto the ground are literally a matter of life and death. For example, in 2005, which was the last year of the study, 34% of all black deaths in Chicago were excess. That is, they would not have occurred if black people had the same death rate as white people. 34%. That number, 34%, comes to 3,200 black deaths, again, in 1905, 1 year, is the number of deaths to black people that would not have occurred had they had the same death rate as white people. That is 3,200 deaths in Chicago due to racism. And if you want to break it down even further, which I think we should do, that comes to 9 black people a day in Chicago every day dying because of racism. 9 a day. And by the way, you know, we're far away from having data for 2010. When that comes available, we'll do the analysis again. And with this economy, it's going to get much worse. So this is an astounding figure. Again, 9 black people a day in the city of Chicago dying from racism. So we announced our results when it came out in the journal, and the Sun-Times picked it up, and this was the whole front page, the whole headline, the number of Chicagoans, the gap is growing. This was an article that appeared in the paper, study blames racism and poverty, and yes, we do. That was the article in the Tribune that came out, so there was a lot of publicity. I might mention that both reporters, in this case, were black, both for the Tribune and the Sun-Times. So here are some more permutations of the data, that is other ways of looking at it. As you may be familiar, Chicago has 77 officially designated community areas. If you take life expectancy, which is the single, if we had to choose one measure of health, the single most important measure, how long people can it be expected to live at birth, and you line them up from lowest to highest, that is from worst to best. The first 22 of them, that is the 22 worst, and by the way, this is all in my PowerPoint notes, so you don't have to write too much. I see some of you writing a lot. But the worst 22 are all black community areas. All black. And so if you think like in Woodlawn, the life expectancy is 68 years. In Chicago, 74. In the Loop, it's 81. So compare just, it doesn't matter, but Woodlawn to the Loop. 13 years difference in life expectancy. And you could walk from one to the other. Some of you say, well, I can't walk that far, but all right, but close enough. You know, close enough. You could bicycle, you could jog, it's all doable. but all in the same city, a 13-year difference. And again, you know, you have to bring it down from the statistics to what it means in real life. I mean, you know, what does it mean for old people like me to lose 13 years at the end of their life like that? And think about our parents and so on. So it's really an amazing situation. This is incredible. In our paper, we found, and Shirley and I used to work on this all the time, that in 2005, when we published the paper, the black infant mortality rate in Chicago was 14.1. That's 3 times higher than the white rate. But to give you an idea of how awful that is, okay, 74, in 2005, 74 countries in the world had lower or better infant mortality rates than black people in Chicago. Now, when you hear that, you say, oh yeah, well, we know the Scandinavia and Sweden and Denmark and Japan, and that's all true. But I wrote down some of the countries that you wouldn't expect to see on the list. And just look at them. Jamaica, Argentina, Russia, Bosnia, Puerto Rico, Poland, and Cuba all have much lower infant mortality rates than black people in the city of Chicago. As a result of that, again, I keep, you know, for me in speaking, and I know you all understand it, but can't emphasize enough, it's literally a matter of life and death. Because of the disparity, not because of the infant mortality rate, but because of the disparity in the infant mortality rate, 3 black infants die each week. Each week. Every week in Chicago, 3 black infants die because of racism, because of this disparity. Every week. 2 black women die each week because of the disparity in breast cancer mortality. So just imagine that again. You know, our mothers, our aunts, and our daughters, 2 of them each week because of the disparity, because of the racism in breast cancer issues. Here's more of a context. Just a couple of weeks ago, the New York Times had this editorial talking about cholera in Haiti, which is becoming an epidemic there, as you know. And you can't quite see, but CDC estimates that it'll cost $1 billion to fix the situation. The New York Times supports that. Of course, I do, and I know all of you do as well. $1 billion is probably about 2 days of war in Afghanistan, for example. But here's the death rates when you put them all together. So the cholera in Haiti has a death rate, and we don't have to go through these numbers, 0.07, 9/11, which we talk about all the time, where 3,000 people died, and that resulted in this death rate, which as you can see is much smaller than that. And racism in Chicago is the biggest here. Okay, racism in Chicago is much bigger. That's what it looks like. This is 9/11, cholera in Haiti, and racism in Chicago. Now, what do we pay more attention to? What's the vocabulary about? Where's the money spent? And so just look at this. So here are proposed remedies. Okay, for cholera in Haiti, they propose we spend $1 billion. Again, we all agree that we should. For 9/11, we've spent trillions. Now these numbers are so big we don't even know what they mean really. But trillions of dollars. We've murdered millions of people across the world in response, and we continue to bomb and drone everyone in sight that can be found. And none of this, although I concede I'm half crazy, none of this is an exaggeration. Racism in Chicago. What have we done about that? Well, we've made cuts. We've also made cuts. And finally, we've made cuts. And we've decreased spending on all issues. Women are dying from breast cancer, babies are dying from infant mortality, but we've made cuts. And the notable thing here, by the way, is that for cholera in Haiti and 9/11, those are one-time events. Racism in Chicago, I'm just talking about the results from 1 year. But it goes on every year. And in fact, my hypothesis, since we'll look at the data, is that it keeps getting worse. Okay, let me talk to you about some other ways in which we've come to understand disparities, and I'll try to finish this up. But a while ago, we conducted the biggest survey in the history of Chicago. We did it in several different community areas. I'll talk about that later. Anyway, here are just some of our findings. So, for example, off of the community survey, and again, stop me if you'd like, but don't feel compelled to. There is, these are people who smoke in the different communities. And in the United States and Chicago as a whole, it's roughly 20%. And Mount Sinai Hospital, which is right down the street, is in North Lawndale, which is an all-black community, very, 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 very poor. And roughly 40% of people in North Lawndale smoke. Now, to give you a sense, 39%. Yes?
Where is Lawndale?
What is it?
Where
is it? Well, you know, it's a whole community area. If you go right down Ogden Avenue from here, you could walk there.
Going southwest.
Going southwest. And it's roughly like Mount Sinai, which is in North Lawndale.
That's North Lawndale. So
Is
Sinai
that-
is North Lawndale.
Well, there's North Lawndale and there's South Lawndale.
Right.
North, in Chicago tradition, North Lawndale is all black, South Lawndale is all Mexican.
Gotcha.
North
Go back to the community.
North-
Go back to the community. Go back to the
What now?
community. You're going back to the community map.
All right, that's right. Aren't you? Good. Here they all are. I don't know. Is this- Thank you very much. So we're here in community 28, I think, and right there, 29 is North Lawndale,
Okay.
and 30 is South Lawndale, so all black and all Mexican. Sinai is right here on the corner. And by the way, North Lawndale is where Martin Luther King lived when he came to Chicago. So right down the street from Mount Sinai, and he lived there because it was so poor and oppressed, and he wanted to call the nation's attention to that. So smoking is huge, 40%. The last time the United States smoked at 40%, which is in North Lawndale, was 30 years ago. So saying that another way, North Lawndale is 30 years behind the smoking cessation curve of the United States. This is interesting. This is depression, and what we found, these are the 6 community areas we studied. But this is quite interesting because we pursued this in a different way on our survey. We randomly selected households, went into people's households and asked them questions. And what we did was we asked them, have you ever been diagnosed as being depressed, which is the way that question is asked on all national health surveys. But in addition, we gave them a 10-question scale, which comes from the Center for Epidemiologic Studies. It's the depression scale. And administered that to people who said they had never been diagnosed as being depressed. And that's the yellow part of the bar. The blue part of the bar is the depression, is the diagnosis. And so look, when you add those two together, 40%, almost half of all adults have problems with depression. And as you can see, if you've never been diagnosed, there's no way you could get services. Now, given the state of things, even if you have been diagnosed, you can't get services. And the city, of course, has just closed down 5 mental health clinics in Chicago. But anyway, we could go on and on. This is a percent of children who are obese. I don't know if you've heard about this, but there's an obesity problem. I don't know, you've probably not heard about that. But anyway, what's going on here is quite extraordinary. In the United States, being either overweight or obese for children, 26%, roughly 1 out of 4. Look at it in these communities, say again, North Lawndale, where my desk is, 68%. More than 2 out of 3 children obese. And that's the same in all of these communities. So a huge, huge obesity problem far beyond what's going on nationally. And if what's going on nationally is a major epidemic, then what is 2 or 3 times that here in Chicago? This to me is one of the most extraordinary results. I'm sorry, I know I'm in your way. I guess if I stood here, that wouldn't happen. But this is the proportion of parents of children who were overweight or obese who thought their children were the right weight or underweight. And the answer is everybody. Virtually all parents of overweight or obese children thought their children were the right weight or even underweight. So it just raises interesting implications for doing interventions. You know, if you hang up a sign and saying, we can help you stop smoking, then people know if they smoke and they can take that offer up or not. I mean, they may not tell us if they smoke, but they know whether they smoke or not. But just imagine going into a community, say, and hanging up a sign saying, we can help your obese children. And parents say, well, cool, my kid ain't obese, you know. So there's a lot of education to be done in that area, as we all know. Anyway, I want to skip this and move ahead. It just gets worse and worse. Okay, so let me just say, so I've always been astounded by the fact that so many health researchers, so many epidemiologists like myself, do research, find these problems, find these disparities, find terrible problems, publish the papers, get promoted, get rich, buy a summer home, and then keep on walking. You know, and to me, it's always been like seeing a bleeding person lying in the street, and you step over the person and just keep going. So we refuse to do that. And the premise, and Shirley and I devoted our lives to that when we were at the health department, and now at Sinai Urban Health Institute, is we've got to do something to make matters better. So we've developed what we call the Sinai model, and it has these steps in it. It's a long story if you want to know more I can tell you, but you know, we try to do good research, we document health disparities, we disseminate the findings in both lay journals, as you saw in the newspaper articles, and professional audiences, peer-reviewed journals, conferences, and so on. And we try to use that dissemination to assemble resources for interventions. We meticulously evaluate what we try. We're not defensive about it, so if we don't succeed, we tell people as well as when we do succeed. And the goal is ultimately to improve the health of vulnerable communities. That's what we want to do. So let me show you 3 examples of our work. And so in breast cancer, that's the graph I showed you. It's a little different than before, but just the details. So the concepts, the same, the huge disparity. See, in 1980, they were equal, like I said. Now there's a huge disparity. This is how the disparity has grown over time. Just look at it, 2%, 4%, 16%, 21%, finding 62%, an enormous disparity. And here, Chicago is uniquely worse. So, for example, there's the disparity in Chicago when that study ended, 62%, 41% in the United States, and interestingly, 27% in New York City. So not only is the situation terrible in Chicago, but it is uniquely terrible. And again, all of these papers are published on our website if you want to read any of that. So here's some of our papers that we published. A lot of, as I said, publicity in mass media. Here's an op-ed piece I wrote and some other articles about our work. And so we've been able, using that information on disparities, to attract a lot of attention and put a lot of programs in place to try to make things better. And again, I can talk to you a lot about it, but as Shirley mentioned earlier, well, maybe when we were talking, we've attracted attention for navigation at Mount Sinai, which is very poor, and people get lost in the chaos. It's a terrible situation. But the navigators now have essentially cured that. It's amazing. And we've done navigation in the community. So we've gone out and found women who have no medical homes, who normally would never have mammograms, who don't trust the medical system, use people from the community to go out and find them. Anyway, we can go on. And we founded something called the Metropolitan Chicago Breast Cancer Task Force, which is now an independent organization, but founded, as Shirley mentioned earlier, on our data. There is our initial report, again, on our website, and a flyer of ours. In pediatric asthma, we've done similar things. I showed you earlier, but went through it. The asthma rates are very high, twice what they are in the United States. 25% of children in these communities with asthma. 1 out of every 4 children with asthma. And it's not just like they have a diagnosis. Their lives are being wrecked by it. And not just their lives, but their families' lives. You know, a kid wakes up in the middle of the night not being able to breathe, which is painfully common. Everybody goes to the emergency room. And then the next day the kids can't go to school, the parents can't work. I mean, really, it's just awful, as you know. We found, and we're the first people to discover it, that among the groups in our survey, the Puerto Rican children had overwhelmingly the highest rates, 1 out of every 3. Now, for black people, it was 1 out of every 4, which is awful to begin with, compared to the 12% nationally, but very, very awful situation. Going back to the smoking data, remember I showed you smoking data? Well, in all of these households, half of the adults smoke in the households of children with asthma. What's the worst thing you could do to a child with asthma? Blow smoke in its face. And yet, so here this is. And what are we doing with that? Nothing. Okay. Millions and millions, literally billions of dollars. I want to make this clear. Billions of dollars have come to the state of Illinois as part of the settlement with the tobacco companies, and virtually none of that money has gone to smoking, and really none of it has even gone to public health. Most of it has gone to build prisons, because not quite everyone yet in Illinois is in a prison. So we need more of that. So there's been a lot of publicity about that, and people have generously covered our work. There's a very nice article in The Defender and so on. Some more about publications. And again, we've been able to attract a lot of funding. We use people from the community health workers. They go into the households. They help the families clean up all of the asthma triggers, the mold, the pollution, the rodents, the rodent feces, and so on. And the program's been amazingly effective. And we've evaluated it carefully, so emergency room visits have gone way down, hospitalizations have gone way down, bad episodes have gone way down. And again, to be quite honest, it couldn't matter less to me, but it apparently matters to a lot of people. We've saved a huge amount of money, between $5 and $13 saved for every dollar spent. So that's been very nice, and there are just some more slides. Those are just showing all the improvements we've been able to bring about. I'll skip over that. I just have to tell you this story. So in one of the programs came to an end, and right across the street from Mount Sinai is a big park called Douglas Park. Again, we can walk there from here. And so when one of the programs came to an end, we had a celebration, and we invited all the residents in the park. About 300 people showed up, and we rented these balloons, that blow up into slides and all of that. But we had this rule that the kids had to take off their shoes, because otherwise we're afraid they'd break the balloons. And so here's a mother telling her daughter to take off her shoes, and several of our community health workers were fussing at the children, to take off their shoes. The kids, of course, didn't want to take off their shoes, a bunch of them. And frequently I was standing back and looking, and there'd be these arguments, and the kids would say, I'm not going to take off my shoes. And the community would go, you better take off your shoes. And they were arguing, and it was amazing to watch, because the subtext was, the background of the information was, that many of these children, and this is not an exaggeration, when we met them, they literally, this is not an exaggeration, they literally couldn't get off the couch or out of their beds to get to the door to open it up. And now the paradigm, the argument was whether we can get them to take off their shoes so they wouldn't break the balloons. And it really just an astounding accomplishment, and we could do that easily. And on top of that, we could save a huge amount of money. But will anybody fund that? No, of course not. So this work was done on a grant from CBC, but then you go to Medicaid and you say, well, we'll save you all this money, which is apparently the only thing they understand, not to mention help the kids be healthy, and they say, no, thank you. So anyway, there's a lot more of that. I'll skip all of that, pictures. We've won lots of awards, okay. So that's just a summary of what I've already said. A huge amount, let me see, I think, oh yeah. No, just, I told you about the cost saving. So the amount we save is an average of $3,000 per participant per year. If we served 1,000 people, which we could do easily, that would result in saving $3 million a year. If everybody, all the children in Illinois who had asthma and severe asthma, so that we could work with them, were put in the program, and just look at this, we could save $1.8 billion over 10 years. $1.8 billion over 10 years, but in Medicaid funds. But will Medicaid fund it? Of course not. And so what's the solution? Cut Medicaid. Okay. So, and they're all concerned. All right. So we've done similar work in diabetes. We published this journal article. I'll skip all of that. We've drawn a lot of funding from NIH and local foundations, Polk Brothers and so on. We've hired community health workers. They've gone door to door in both Humboldt Park, which is mostly Latino, Mexican, and Puerto Rican, and also in North Lawndale. We've screened everybody for diabetes. We've helped people get appropriate care, offer cooking and activity classes, improve self-management techniques. And the goal is, the outcome goal, the evaluation goal, is to reduce hemoglobin A1C. And we have these meters, and we take their blood in their home visits. And we've announced clearly, and I say to you, ladies and gentlemen of the jury, that if the hemoglobin A1C does not go down, we will have failed. That's it. I know, one thing when I was at the health department, and Shirley and I used to joke about this, is I'd go to people and I'd say, so how's your program doing? They'd say, oh, it's really doing great. And I'd say, oh, how do you know? And they say, oh, look, it's 5:30 and I'm still at my desk. Or everybody here loves children. Or, any number of other measures of sincerity or even activity, but never a measure of outcome. So here's our measure of outcome. Now the program's still going on, but we're either going to reduce hemoglobin A1C or fail. And again, I could do several hours on a diabetes project by itself. So the program's gotten a lot of media. Just show you one finding from it. The prevalence to diabetes in the United States is 11.3%. And again, we know there's a huge epidemic and everybody's talking about it. What we found in North Lawndale, as we've gone door to door, is a prevalence of 29%. So if 11% is a terrible, terrible epidemic, what is 3 times that? Okay, and it gets much worse, and I won't go into any of that. So here are some of our cooking classes. There's one supermarket in all of North Lawndale named Leamington's, owned by a local family, since all the chains have moved out. And they're lovely people, and we work with them. And they've let our staff put on these labels on all the foods in the supermarket. And it says recommended as diabetes friendly. It's really terrific. And they have a big parking lot, and we have health fairs there in the parking lot, and we hire a DJ and lots of good music, and sometimes people come to watch me dance alone is enough of the truth. So we do all of this. The foundation of all of this is to hire people from the community to do all the work. Okay? That does several things. One is it allows me to take naps several times a day. But the other thing is, they're the only ones who could really do this. I mean, I can't do anything except sign my name, really. And so they do everything. But it also enormously builds the community. When we hire people, we hire them full-time, and some people, professionals, approach me and say, well, Whitman, it's foolish to hire them full-time because you have to pay them benefits and it raises the amount of money you spend. And I say, when I don't get them, I say, not that I'm a violent person, I say, I want to pay them benefits. To me, that's what this is all about. Because you pay them benefits, you give them health insurance, they stabilize their families, they learn a career, they grow, and they become a resource for the community. And so, I can tell you now, we use them in breast cancer, pediatric asthma, diabetes. Virtually all of them by now have reputations in the community. And they'll walk down the street and someone will say to them, hey, aren't you that diabetes lady? You know, and they'll say, yeah. And they say, well, what about, should I be cooking this? Or should I reduce my salt? Or how does it work? Or, hey, aren't you that pediatric asthma lady? You know, yeah, and I can't tell the difference between these medications. So I don't know about all of you, but when I have a question, you know, I know 8 doctors. And I can call them up to answer my questions. People in the community, in these vulnerable communities, don't.
That's right. That's right.
And so it's practically impossible to ever talk to a doctor, for example. And I don't know if that's good or bad, by the way. But I mean, so Shirley says, finish up with it. All right. So we do a lot of work in the community. This is Puerto Rican Day Parade. This is our breast cancer team in Humboldt Park. This is State Representative Cynthia Soto, who's a good friend of ours. Does anybody know this, who this is? I'll give you a hint. It's the next governor of Illinois. Anyway, it's Lisa Madigan. So I want to make it clear, I do not know Lisa Madigan and she does not know me. But she's friends with Cynthia Soto and they both showed up at the parade and we had a huge contingent and a float. There's our float back there, of course bilingual, and you'll especially want to look at the legs on this guy here. Very notable. Anyway, this is more breast cancer stuff, us getting an award from the Avon Breast Cancer Foundation, more about people. We had a huge demonstration so there's this enormous disparity in breast cancer, right, that you show me, everybody now is talking about it, and I'm so pleased about that. And so what has been the response of the state of Illinois? Well, of course, cut back and eventually eliminate the program that funds mammograms for poor women, the Illinois Breast and Cervical Cancer Program. So we had a big demonstration, 500 people in the loop, and marched to the State of Illinois building. This is the demonstration. More pictures of that. This is a big contingent from Pilsen, mostly Mexican, a contingent from Chinatown, and so on, demonstrating against that. This says only 1 in 8 can get a mammogram, that's unacceptable, and on and on and on like that. So more pictures about that, some about community work. Here we are in Leamington having an exercise class or session. Community health workers there. So here's what's what. Okay, first, to me, I think probably you all understand this, but this absolute nonsense about us living in a post-racial society is just one of the dumbest things I've ever heard in my life. If we're living in a post-racial society, why are all these black people dying from racism? Babies, mothers, and so anyway. And there have been any number of books on this topic. So those of you who like to read might find some of these interesting. This is a wonderful book, More Beautiful, More Terrible, anyway, by Imani Perry. Another book, White Like Me, written by a white guy who's interested in racism, A Whitewashing Race. Again, these things are all in your slides if you're interested. Lorraine Hansberry, anybody ever hear of her? Raisins. Of course, she wrote, among other things, Raisin in the Sun. But, you know, although her plays were transcendent, like Raisin in the Sun, she also wrote To Be Young, Gifted, and Black, and all those other kinds of things. She was an essayist and wrote these amazing, hard-hitting essays. In fact, one time she had a meeting with James Baldwin and others with Robert Kennedy, and they so much called him on the carpet for what the administration wasn't doing that he stormed out of the meeting and said, I never want to see those people again in my life. And Lorraine Hansberry was the leading antagonist in that meeting, I'm proud to say. But she has this quote, which I've always loved: this manner of admitting the true nature of a problem before setting about rectifying it or even pretending to is of utmost importance. And so we've got to talk about it. And as you all know, I've been astounded, that racism is almost a curse word now. So if you say something is racist, everybody in the room is shocked. How dare you use that word? So we could disagree on whether something is racist or not, but you cannot say that we cannot talk about it. And I don't mean anyone in this room wants to say that, but they cannot say that we cannot talk about it. So Ida B. Wells, so you all know her. Ida B. Wells was born a slave. She in Mississippi, she grew up in Tennessee. She became the leading opponent of lynching in the world, and traveled throughout the world, and eventually was burned out of Mississippi, her house, her printing press and everything, and moved to Chicago. And at one point, a reporter said to her, "Well, Ida, what is it that you people want anyway?" And she said, "Why, everything, of course." And what is the reason why black people can't have everything that society has? For example, health. What could be the possible reason? W.E.B. Du Bois, of course, arguably the greatest intellect in the history of the United States. He co-founded the NAACP and did lots of other stuff. Wrote hundreds of journal articles, 14 books. One of the books he and his colleagues wrote was The Health and Physique of the Negro American. We would call it an epidemiological study. They called it a sociological study. And they found, after systematic study, that black people had much worse health than white people. And they attributed that to racism and poverty. And the kicker is that that was written in 1906, 106 years ago, and here we are still talking about the same stuff. Doña Consuelo Cortier, Puerto Rican national poet, and she said, you know, we have it wrong, and I know you all agree with this, when we say, let's live, how do you say that? Live and let live. And she said, that's all wrong. What we want to do is live and help to live. And that's become a slogan of our colleagues on Division Street in the Puerto Rican community here. I know that's what you're all about, and we have to remember that forever. So the question is, what are you going to do about it? What are we going to do about it? And here are these things, and you all know that. You've been discussing that all morning. I think all of these things are important. Number 4 is important as well as we can. We should tell the truth about racism and oppression. Now, Shirley asked these impossible metaphysical questions. I mean, they're probably not metaphysical for Shirley, but as you can see, I don't know the answers to any of them. But I will, just before finishing, sitting here and listening to you and marveling at what you're saying and what so many of you are doing, I challenge you in the following way. I think what this institute should do is to choose one thing and work on it, one project, with the caveat being that it must be evaluatable. So after a year or two, how will you know if you succeeded or not? And specifically, there are all of these things. You know, we could work on world peace and brotherhood or sisterhood or loving Rahm Emanuel, whatever people want to do. But I can tell you that although the underlying cause of these disparities, as I've said any number of times, is racism and poverty, it's going to take us several weeks to eliminate racism and poverty. And so in the meantime, we have to do something now that matters. So I challenge this institute, and maybe it's not the kind of thing this institute does, and maybe it's a bad idea, and you could all discuss that amongst yourselves. But for example, what about the obscenity, and there's many of them, but of cutting back the program that pays for mammograms for poor women? Imagine what would happen, possibly, if you marshaled all of your energy and all of your resources of all of your institutions and said to the state legislature and or Governor Quinn, this is unacceptable. We want more money put into this program that funds mammograms for women. Because it only funds them for poor women, the vast majority of whom, at least in Chicago, are black, and of course Latino. We demand that that program be supplemented. What if you said that? What if you said something else? We demand that all children with asthma have their medications fully funded. Or we demanded that all people with diabetes be allowed to get on Medicaid if they don't have other insurance programs. I could go on and on. But you know, people think Medicaid is for poor people, and it's true by and large that you have to be poor to get on Medicaid. It is not even remotely true that if you're poor, you get on Medicaid. So we encounter in the community all the time these people who have no insurance. They have diabetes and no insurance. So what if you worked on that? So again, my challenge to you is, pick a topic, and I just mentioned the ones that I've been working in, there, must be 100 more, but pick something like that and say to yourself, if in 2 years, here's what we're going to do, and we're going to come back and look at it in 2 years. And that's how we'll know if we've succeeded or not. If we haven't, it doesn't mean we're bad people, but it means we have to rethink our strategy and figure out what to do. I'll tell you, if we don't change things, as you all know and as you've all said, they're not going to change. So for better or worse, it's up to us. And people like us, of course, everywhere. So I urge that. And so I don't know the names that answer to any of these questions. For disappointment. And finally, we've written a book on all of this. And I apologize for the fact that it's very expensive. It's the last slide in your packet. But I do think it's an excellent book. It makes, by the way, a great stocking stuffer. So if you'd like to buy something for the holidays and give them away, you can do that. But I'm sorry it's so expensive, but it does cover everything we said. So thanks very much.